There we go. Okay,
That'll do it.
there we are. All right, everyone. Jim Augustine, emergency physician, Fire EMS medical director, member of the task force for the International Association of Fire Chiefs and International Association of Firefighters for COVID, which is now emerging health issues task force. And a student of Sarah Janke and others in the group in terms of our ability to improve the lives and the health and safety of our fire EMS providers. So today I was asked to talk about our COVID response, how it fits into the pattern of what we have developed in fire EMS and where we're to go. So this is being recorded and I'm watching chat. So if anything comes up in terms of quality of the program or anything else for me, please let me know. So where we have been and where we're going kind of has these elements. We are surviving COVID. There's still more work to do. We have really filled in the gaps for so many areas in regard to pandemic response. We have helped save the community. We've helped save the American health system, and thank you for what you've done. Our current challenge is still to get through the rest of the COVID pandemic and how we deal with coronavirus, immunizations, updates on immunizations, et cetera. You'll see through this. And then really learn from it to build our systems of preparedness and lessons learned. And as part of this, we really are at a time when we're designing a new emergency and unscheduled care health system. In many ways, it is broken down during the course of this and needs to be updated. And then the technologies, including the Zoom process that we're doing now, has really given us the opportunity to move healthcare ahead for people in the community in ways we've never thought of before. Going back to Johnny and Roy and Rescue 51, we have been the all hazard service every day serving the community. And we are where public health and the emergency system come together. Public health was always designed as an investigative system to look at the science of what has happened, to know how to use that science to apply to people, and then to build future courses of science around what has been learned. Public health, the CDC, has never been built as a first response agency. And working in periods of uncertainty has always been the specialty of emergency medicine, emergency medical services, fire chiefs, EMS chiefs, et cetera. Our job is to protect our members, and by protecting our members, to protect our communities. And then what we have watched is the evolution of our workforce in many areas of this country to be a very sophisticated workforce that is able to deliver both emergency unscheduled care services and public health services. We have built our emergency system around volunteers in many ways, and I grew up as a volunteer in the system. We build it for rural needs, and we have to remember, as we're looking at any of our delivery models, we have to include very rural wilderness areas and in areas where volunteers providing service in a very large land area is their way of doing business. So we have to combine all of those elements together to make sure that we continue to deliver. Our heritage has been around, big events, and if you think of weather events and wildfires, and then outbreaks of diseases, and then outbreaks of man-made diseases like active violence issues and civil unrest over the past couple of years. That's really our heritage in emergency system preparedness. And we have grown very sophisticated, and we've built systems like incident command, moving up to incident management, in mutual aid as ways to bolster our workforce and then to be able to apply management principles widely. That is a fabulous heritage for us to work off of. And we've used it effectively in recent infectious disease outbreaks, SARS, H1N1, Ebola, et cetera. This is really important that we think through and understand this. Our heritage of preparedness in this country began post-World War II, and it began with civil defense systems that were built to respond to a nuclear bomb hitting one of our major cities. And we developed systems of both response. We built hospitals in rural communities in the Hill-Burton Act to be in place so that when the big cities got nuked, when people came streaming out, there would be a place for their care. We built a fire EMS system that could respond to everyday incidents plus the big incidents. We built education programs around, duck and cover and civil defense monikers on various buildings that were supposed to be the strong buildings that would survive, and supplies that were kept there. In the 70s, we recognized, we still needed to be worried about Cold War threats, but that every day people are dying of trauma and cardiac arrest and burns, and we needed to respond to those, and we've responded very effectively to those three real threats to lives of Americans and people around the globe. In 1980s, we began to recognize hazardous materials incidents as a significant threat to individuals and to the population. 2 days ago was the anniversary of a big event in my career and for this country, which was the Miamisburg train derailment in a suburb of Dayton, Ohio. That was 1986, and it was the largest civilian evacuation in history, and still is in America. And that hazardous materials event was the basis for SARA Title III. When we began to develop hazardous materials teams, I got to tell you, we went to the place that had the stores for us for hazardous materials response, and on those shelves were tincture of green soap, cornstarch, and tire brushes. That was based on our heritage of civil defense, and tincture of green soap, cornstarch, and tire brushes were the way that you cleaned radioactive fallout off of people. That's not quite, though, what you need when somebody's been burned with an industrial chemical or with gas exposure to industrial chlorine, et cetera. So we had to restock the shelves for hazardous materials in the 1980s based on not a civil defense radiation fallout model. In the 1990s, we were challenged by bloodborne diseases, hepatitis B and C, HIV, AIDS, et cetera. And we built very good programs to prevent responders and community outbreaks of bloodborne diseases. In the 2000s, we had anthrax and SARS, which were airborne diseases, and we built programs around the threats of airborne diseases. And then we began to develop more response systems for terrorism. In the 2010s, we built programs around active shooter, around another infectious disease, Ebola. And Ebola, for those of you familiar with the science of it, was essentially liquid cyanide on the patient. And our ability to respond to liquid cyanide incidents is what helped us build successful programs to prevent people from getting ill from a infectious disease that is very hazardous and is essentially liquid death in terms of how you had to prevent spread to other people. And then 2020s were in pandemic, civil unrest, active violence events, and unfortunately, we're cycling back, and with the threat of Russia now, we are back rebuilding our stocks of radiation incident materials and our science around what would happen if a nuclear device detonated in this country or in Europe or another place on the planet. So with that in mind, a reminder that we deal with and continue to deal with everyday infectious disease hazards. Those are hepatitis A, B, C, meningococcus, MRSA, C. diff, tuberculosis, and these are not going to go away. And in the middle of all of our COVID responses, we still had patients who had these particular diseases, and we needed to use our bloodborne pathogen preventions. We needed to do contact tracing for these diseases. We still need to wash our hands because C. diff spores are not killed by alcohol. And people who cough on us who have tuberculosis are still a significant risk to us. So ongoing ability to do standard precautions when it comes to patient encounters, not going away. And these and other diseases will continue to challenge us into the future. All right, so then there was 2020. PPE was not available initially, but then it came available. But early on, we were reusing masks, gowns, and goggles. Whoever would have thought that we would be in a position of having developed reuse processes and decontamination processes. Testing originally was not present for COVID. We had to build that program. Then we found it wasn't very reliable, and it went away. And then it's back again. And now it is in convenient form that can be used in people's homes. And that has introduced a new challenge, which is we don't have a good count right now on the number of people who are really sick with the disease, because so many people are doing home tests and not reporting their results to public health. And so we really don't have as good a handle on how many people are ill now as we did when we had public health system controlled testing sites and an ability to grab information from hospitals and clinics and the public health sites to be able to get a good handle on how many people were sick. Outbreaks in the system continue to move us to distancing and masks, and then very sophisticated processes for quarantine and isolation, which is Q&I. And then really, again, the ability for fire EMS systems to step up to do testing, vaccination, education about PPE, prevention in our particularly high-risk areas, which are congregate care areas, senior care facilities, et cetera. We have impacted community beyond our ability to run out with red lights and sirens and transport somebody to the hospital. We have been very active in developing other programs that served our communities, including, very importantly, public education. Number two, we've done testing. So we took our members with test kits, dressed in PPE, into nursing homes and other sites to do testing. That's generally not been the heritage of fire EMS systems to go do that. We built and carried out monoclonal administration programs for our nursing homes. In one of my cases, we had a large outbreak in a nursing home. The way to end that was to go in and to treat the people with the monoclonals, which we did using fire EMS resources and our community paramedics. We went in and ended that outbreak in that nursing home by us going in and doing something not traditional, which was administering the treatment in the facility. We have also been involved in educating our populations about proper use of quarantine, isolation, and PPE. Okay, so early on, we had to work through a system where there was imperfect science. Again, I will say imperfect times when there is uncertainty around what the threat is and how to manage it. That is our heritage. That is where we are really good. We will use the best available information to come up with the best response and be able to develop the best product for the best outcome for our communities. Thank you for what you do, and we are all part of that collectively. And we quickly adopted the best safety practices that we had, and we shared them widely. And we shared them in our communities with groups like law enforcement and corrections and the 911 centers. And we developed consistent programs so that within our community, when people saw emergency providers or talked to them on their phone when they dialed 911, they got very similar answers. We were using similar decon processes. We were using similar distancing processes. We were using similar quarantine and isolation policies, et cetera. That's really important. What was weird was, like in the picture here, us coming to deal with them with a very different look and sometimes very inconsistent looks, because one part of the crew is in a gown and one part's in, a full face respirator. In some cases, we had plastic bags on us. We are doing our best to protect our people in order to deliver service in the community. But we were developing this using the best products and imperfect knowledge of what to do. We also had to quickly develop the data that allowed us to track our own operations, to track hotspots, to track outbreaks that were occurring both in the community and within our stations, for example. And so we were developing the process that got us to dashboards and to hotspot management, which we will use into the future very widely. We also went out again into places looking for trouble and looking for opportunities for us to serve people who needed service, and essentially not waiting for the 911 call to come in and ask us for assistance. That's what we do, and sharing best practices and learning about the politics, learning about disinformation, learning about the impact of social media. We had to develop an action plan for how to manage all of this together. I work with the other big system medical directors in the country in a group called the Eagles, and we're trying to put together our thoughts about how to manage this as we move through from 2020. And what we really had to develop early on was the idea that our systems were going to move through theaters of operation or phases of operations. And when we put those ideas together, we came up with the fact that there are 5 theaters of operation in terms of serving our communities for public health events. So let's go through those. The first is when there's an active emergency, when the fire is spreading and we don't have good controls on it. And we need to develop an initial action plan for how to deal with that fire as it's beginning to move. And in this case, it was a new infectious disease problem that was moving through communities. There were no vaccines. There was relatively easy spread until we began shutting things down. We had our very high number at the time of COVID patients, major stresses on fire EMS services, on our members because we didn't have perfect protection for them, on emergency departments, hospitals, and healthcare systems. And in many ways, we shut everything down in order to accommodate the load that would come with the patients who had the bad disease, which was COVID, without vaccination and without known effective treatments. At that time, we were losing our members to the illness and losing confidence that we knew how to manage this incident and threat. And so it was not a good time in the system. So think about this as springtime, winter, springtime 2020. And then we had a reprieve over the summer, and then we were moving back into it in the fall. And at those points, we are significantly having our own people at risk. Hospitals became full. It became a challenge to get EMS patients into the hospital system and then back out on the streets. So we began to include things like patient offload delays or pods, or what were called wall times in many of our systems. We had to learn about really the health of our members and how best to deal with it. What exposures did we need to quarantine for? We had to take our industry and turn it upside down because, very bluntly, everybody comes to work at fire and EMS in the emergency department unless they are laying on the stretcher. We had people who came to work sick as hell from every other disease. And then all of a sudden we told them, you get the sniffles, we don't want to see you at work. You come to work and cough once, and everybody's going to move out or throw you out of the building. That's a real change in philosophy in an entire industry that had to flip essentially on a dime. Monitoring our members' health we were able to pull from some guidelines, and again, at an imperfect time with the science, what period of time do you need to stay home for? Where do you need to be? What kind of mask you need to use? Where do you need to go to get tested, and how can you do that safely? And then OSHA and the CDC began working on restrictive guidelines, and for us, that's under the general duty clause. But also, as people are dying or getting very sick, our members' mental health was really challenged. In one of my departments, we developed the 14-day health record system so that every day, people who had been exposed, and after a certain period of time, everybody had been exposed. Everybody knew someone, everybody had taken care of someone who had the disease. We couldn't put everybody off work and shut departments down completely. And so we developed this 14-day running system of monitoring people's health, looking for key symptoms. You remember early on, the early form of COVID was loss of taste and smell was a very sensitive way of predicting COVID. And we were monitoring for that. And then twice a day, we're monitoring with a thermometer, which didn't turn out to be a very objective, accurate test for COVID, but it was the best objective measure that we had until we realized for people who were sick how important the pulse oximeter was. Nonetheless, we will now have the 14-day symptom checker for diseases, so that anybody who is exposed to anything at this point, hepatitis, tuberculosis, MRSA, we will be able to give them a form and a philosophy of, we're going to continue to check on your health at appropriate intervals to make sure you're still healthy and not developing the symptoms of the disease that we're looking for. All right, into our real costs. And, here was an early picture of our members lost to COVID. And on this page, I know two of the people, but one in particular was a guy I worked with for 30 years. He also happens to be my son's father-in-law. And we lost a healthy 52-year-old fire lieutenant and paramedic to the disease, who really didn't have any other risk factors, but just caught the devastating course of the disease. And like all of these people who are pictured here and many, many others, the real cost became very personal, because essentially everybody in our industry knew someone who died of this terrible disease. Okay, phase one, depressing, very, very poor knowledge of the disease, not a vaccination package available, and treatment that was very crude at best for managing the disease. We were looking forward to, though, launching the second theater of operation, which is getting the vaccines into people to prevent the disease. So the second theater was about launching the vaccines, which was much more complicated than had ever been planned for. Nowhere in the pandemic playbook is there a process for having multiple vaccines available that essentially people began to choose from based on the best information that they had available. And then our playbook had never been built on that you had to have multiple vaccines. And originally it was 2 vaccines. And in one case, it was 3 weeks apart. And in another case, it was 4 weeks apart. And then a single vaccine that had more side effects, but only had to be given once, but had lower effectiveness. And how do you educate the public very quickly about these options and let people pick and choose which vaccine they wanted to receive? The CDC quickly built a program, understanding that they had to shortcut the process to get to the vaccines, to learn about adverse effects and what affected people after they had gotten their vaccine, and were they safe from the disease or not. And so they quickly built a program. And after my vaccine, I got daily, then weekly, then monthly requests from the VSafe program on my phone. What's your health like? Have you had the disease? Have you had other problems? That was an all new build. At that time, we were encouraging fire and public safety agencies to cooperate and get the vaccines. Unfortunately, some of our members still have not been vaccinated, and that's their choice. But the public was looking to us for confidence in the vaccination process and in the vaccines. Our uptake probably about 60%. At this point, many more than 20% in the industry have been infected. And still opportunities for us to get more of our members vaccinated. And the question is now how many, and do you need boosted or not? And we're at this point almost up to 5 vaccines, and we moved them through the population to the point where we're now down to the 6 months of age range. We know about immunizing events, which is a combination of vaccines plus having the clinical illness. We don't know how many of those people will need to achieve full immune status against this disease, or maybe at this point it will always be just partial, and that new variants we're going to need to go kind of chasing, if you will. And another piece to this is we are recognizing that until you have a disease controlled across the globe, any community can pick up that disease based on something that has been created in another country. We'll talk more about that later. All right, the third vaccination as we move from initial vaccine launch was then having the mass vaccination. And here we have plenty of vaccination available. Now it's getting people lined up in cars or in walk-in sites to be able to get the vaccine, making sure that we get to high-risk populations. We tried to start off with the population most at risk, which was the seniors, moving down through the age group, and then eventually getting to both the quantity and the quality that gets us down to the 6 months of age. Making mass vaccination sites very efficient to get in and out of, and yet making sure that we take care of people that are there on the site who are going to have a vasovagal episode or some kind of adverse reaction, which we found very rarely. So our fire crews and EMS crews very, very active in the mass vaccination sites. And we developed very efficient ways to move millions, then hundreds of millions of people through those vaccination sites. And we still have that process in place, although right now nothing is moving at the mass vaccination level. All right. Again, this is a little comic relief at this point. Understanding my job as a medical director is still to get enough people immunized that we have an effective department, that we don't have big risks either within our stations or out in the streets. And a little bit about how people are getting their information and what becomes reliable sources of information. And it is very hard to undo something that people have fixed in their mind because they read it somewhere on a screen in black and white, and it said very clearly there was some risk that was not pleasant or amenable to them. All right, as we're going through mass vaccination, we're thinking about the next 2 phases. And one is, how do we safely wind down pandemic operations and restore our communities to levels of activity? And then 5th, you're going to hear about here, we're all the time through this creating vacuums and gaps. And how are we going to begin to fill those? So 4 and 5 kind of go together. But our safe wind down of the pandemic operations include, how do we get to a new normal? How do we reduce our use of PPE, reopen all of the stuff that we do? Today in the station that I'm here at in Florida, we have 50 preschoolers coming through to do their routine introduction to the fire service. And wandering through all of our places, they're going to go down the hallway here at some point and learn what a fire station is and what fire protection is, and about stop, drop, and roll, and about fire prevention in their homes. That's all stuff that was on hold for 2 or 2.5 years. And we weren't doing blood pressure checks here in the station, and we weren't doing our other community events that are so important to the health of our public. So those are things which we need to safely spin back up. And at the same time, we're spinning up those kind of operations. We're also spinning up a new way of delivering pre-hospital care, and includes programs for those of you into this like ET3, where we're delivering more treatment in place. We're using community paramedics to deliver both medical care and a very important element for delivering mental health care out in the community, learning new ways to serve our communities. And then that fifth theater I talked about, which is we have created massive voids. We have created people needs that are very significant. And many of our older members retired out or left because of the stresses of the pandemic, or their basic life situations, or the loss of their spouses. You know, a number of things have now come to affect how we can keep members showing up for work and doing a very effective job at what they do. Our educational institutions have been gutted at the expense of both operations and the safety of our personnel. So we have to rebuild our educational processes and rebuild the recruiting pipeline, and then rebuild the retention pipeline. And then other things we know need to be rebuilt, like the safe design of ambulances, so that our staff members don't have to worry about getting infected in the back of the unit and in the station. And for me as an emergency physician, rebuilding our emergency departments so that we aren't working in tents outside receiving patients like we did during the COVID outbreak. So it's really important that we remember in the future, there's 5 levels of operation. And as we start into the first one, we need to be planning ahead for the other ones and how we're going to build the platforms to carry each of those out successfully. All right, so let me say now the checklist for the wind down is our current wave is the Omicron wave, and this week it happens to be B5. That is a very infectious form of COVID. It moves through even people who had been vaccinated, and their immune status is beginning to wane. We need to get as many people vaccinated as possible, and then probably this fall tweaking the vaccine to account for more of the Omicron variants. That is the same thing we do each year for influenza. And so we're moving into a process of tweaking the vaccines very quickly to get to protection, as we do with influenza each year. We need to tweak the testing process and the need to be able to deliver it at homes and in organized spaces so that people know where to get a test, how to get a test, and how to deal with whatever the results are, positive or negative. I still don't think there's a great chance of contact tracing at the local level because right now the incidence is too high. But at some point we will be back to contact tracing for individuals who've been exposed. We need to write our excellent after action reports that guide us into the future. So that is really on the agenda right now in many of the agencies that I'm involved in. And it's developing these things like theaters of operation, extended times where we're operating under emergency circumstances. How do we not have it impact our day-to-day stuff as dramatically? How do we use imperfect science to still be able to make good policy and guideline decisions? And how do we change systems of care so that we can deliver it outside of the hospital and emergency departments? The science of the disease still has to be figured out, which is levels of antibodies that are effective. How does that impact our future decisions about what kind of boosters to give? This fall, we're going to have another outbreak of other respiratory diseases, and we need to get ready for it. How do we get our people to take the flu vaccine this fall, along with any updates on COVID that will be needed at the time? And then really a public health emergency. What do we need to learn about politics and accurate, skillful, timely delivery of accurate information to the community as well as to our own members? So where we are now, waves of the COVID bug that have gone through. They're not at this point on an annual schedule like influenza is. It's more like in every 6 months, we're seeing new waves of COVID go through. The B1 was from the UK. The B1 351 was from South Africa. Brazil was another gamma, which didn't get very good footing across the globe. We're now at Omicron, which came out of Europe again. And now we're at the BA5 and the BA4 outbreaks, which are going through, and again, are known to be very infectious. They have a different type of infection that happens to be not as serious, but we believe at this point. So a lot of our members and me have been sick with the new subvariants of Omicron and have not been hospitalized and not been ill enough to spread it effectively to a whole lot of other people. That's been one of the other natures of our summer outbreaks, is we've had the first wave go through, and then you're looking and waiting for the second waves to occur, and they're not happening. We've also noted that deaths are down and that hospitalizations are down. Nationally, we're at levels that we haven't seen for a long, long time in terms of COVID hospitalizations, and the people who are in the hospital typically are much older and compromised than they were with earlier variants. All right, right now we're looking at our PPE policies, and where there is substantial transmission in the community, we're still using universal PPE with our upgraded respiratory protection, and using it during anything that is a patient encounter, and keeping unessential members away from the patient the way we did early on. In places where there's minimal to no community transmission, then we use selective PPE for respiratory or otherwise potentially infectious patients, and gloves and masks for our routine patient encounter. So PPE policies have been modified down to, again, use them. And in particular in the summer months, let's be very honest, it's not easy to wear full PPE in the summer months on a trauma event where somebody is, fallen or wrecked a motorcycle out on the streets, and it's 120 degrees. It's not easy to use PPE, and we shouldn't be using up our PPE in circumstances where we're really not preventing an exposure. I just put this up there as a reminder because this is the Science Council, that we still have our controls. We're still learning to use these effectively. Each one of these has a place in reducing infectious disease and other risks to our personnel. PPE is one element of that, and the other is in our other administrative controls and work practices. Still things like keeping unessential people out of a 6-foot radius around the patient to make sure they're not exposed inappropriately, and that we're not bringing dirty materials back into the medic units or back into the stations where they potentially are infectious to other people again. All right, and then I'm going to put this in context. Over the last 2 years, what has killed fire and EMS personnel the number one remains to be cardiovascular disease. Number two in recent times has been COVID. Number three, vehicle accidents, both on and off duty. Number four, and a continued risk, is cancer. And a lot of what we are working on within our industry is cancer prevention. And as we prevent cardiovascular deaths, we need to remember that everybody has to die of something, but we want our retirees to be going out healthy, and we want them to be going out with the least risk of cancer and other major diseases for as healthy a retirement as they can get to. We will continue our work in cancer prevention, but understand as we get to a longevity in this industry and we move people through a variety of risks, that cancer has to remain a risk to them, when they get into their 90s and 100s, hopefully, that it is very likely that cancer is what will take them out. And then finally, scene operations, and it's still really important that we operate at our emergency scenes safely, avoid getting run over, avoid having a building collapse on us, avoid getting shot by somebody when we're out on the scene. Recognizing also when we do our work that EMS responders have other risks that firefighters do not, and those relate to patient movement, contamination from patients, and the equipment that we use to take care of them. Recently, there have been weapons involved on patients and shooting, the EMT in the back of the medic unit, or escaping and knifing them, stealing the ambulances, et cetera. We have risks in this industry, and they seem to be in some areas expanding. So EMS has some special risks which we need to take into account, and again, use all of those controls available to reduce the risk to our people. Drug and supply shortages. Who would have thought, we would be looking at a summer, and last week my publication had to be on the shortage of dextrose solutions that began with D50 and now is at D10, and even is at the point where D5 solutions not available. Each of those, when we don't have the drugs that are necessary to treat the patient, put our providers at increased risk of stress, of a reaction by the patient when they don't have the treatment that's available. And like all of you, I've fought with, diabetic patients who have a hypoglycemic reaction who are violent, and you don't have D50 to provide a restoration of their blood sugar and their usual mental status. They're still kicking and swinging and diaphoretic and hard to control. And that puts more of a risk on our people every minute that we can't get their blood sugar back up to where they quit being violent. Our outbreak of mental health and substance abuse in our communities puts our providers at risk every time they're dealing with people who are not able to control themselves, and then express that as violence against our providers. And then the reality that there are people who are just intent on killing others. And recent, weeks have had two of these horrible events occur in this country. All right, COVID now, all hazards approach, that's good. Consistent, effective safety strategies, still a good idea. We have taught people how to use incident command and mutual aid that never used it before. So we now have it effective and available for us to use in other industries and people around us, including our public health people who know about incident command systems now and about mutual aid. And we know that communications matters, and that's communication amongst our industry as well as communications out to our public. The lessons that'll come, we were 100 years from the 1918 influenza. The playbook developed for that began with things like closing the schools, keeping people at home, which haven't worked as effectively in this pandemic, which did not feature children being the primary spread agents and the people at the oldest age being at highest risk for death. Each one of these, as I tried to point out, we learned a little bit something that contributed to our long-term industrial safety. And in this outbreak, I think we had far fewer members who would have died from COVID than would have died in the 1918s in the hospital and healthcare environment that treated influenza at that time. Mother Nature will continue to say, I'm the ultimate bioterrorist, and I'll come up with new ways to challenge you. Omicron is infectious and fortunately less severe. And then I want to point out all of our science. One of the best scientists that we have run across in this pandemic has been Mike Osterholm from Minnesota, who early on developed this curve called the Osterholm curve that predicted our outbreaks really well in this country in its initial run. And if we looked at the actual CDC counts through the first 4 peaks, we followed this curve very, very well. And so that's what the curve looked like for a very long period of time. And then, and it took it out here. And then what happened was Omicron came through and essentially wiped this whole thing out. And we had so many people who got sick from Omicron, it dwarfed the number of people who had been seen in the 2020 fall peak. So even Mike Osterholm and others had to learn, gee, we have waves that are going through, and we have a new variant that goes through that's very infectious. It can wipe out what we think we know about the science. I also want to point out this relationship with public health, and a picture here of a dashboard. We learned about dashboards and hotspots, and we've known about that in the fire service for a while. We've had hotspots for fire danger and for arson danger and for opiate overdose dangers, et cetera. And we have combined what we knew in the fire service with both what public health does and knows about. And we began to look for hotspots. And when you get to hotspots, then you say, okay, what do we do about those hotspots? Do we prevent? Do we test? Do we communicate? Do we treat in different ways? And I've already mentioned in a couple of circumstances, the way to move through hotspot management was testing more widely and keeping people home who were at risk to those that lived in the hotspots. We have done treatment like going and delivering monoclonal antibodies to people who were in the hottest of hotspots in order to break the cycle of the spread. And we will continue to do that. And right now in wildland areas, they're monitoring for hotspots in much the same way. All right, I'm going to give you 13, really, really good things we need to learn from this and need to be part of our pandemic after action report. Number one, each one of these gives us a better idea of how humans react to viruses and other infectious diseases. It is really weird that this pandemic did not feature kids dying, and that's never occurred before in the history of humanity. We need to learn about PPE. We need to learn about transmission within buildings and why it's a whole lot safer to be outside and how do we replicate that inside building. We need to know early on about symptoms to worry about. And if symptoms aren't good predictors, then what else do we use to predict and know when people are sick? And that goes back then, if you don't know when everybody is sick, then you have to keep them all away from each other and put them in PPE. Testing will never be 100%, particularly when it comes out early on. We need to learn, though, how to use testing to put people who are at risk in a better situation. We're learning about long COVID. We still don't know very much about it and whether long means beyond 2-3 years, because that's all the further we are into this disease, and what things we can do to prevent long COVID from happening. And we believe at this point that if you vaccinate people after they've had the disease, that vaccination may reduce the incidence of long COVID. That will be new knowledge in immunology. We will learn a very important part of our after action is we got to have a very consistent supply chain for our critical supplies. It happened that much of the medical supply industry is in the area around Wuhan, China. And so this was a perfect storm in terms of both the disease coming from one area of China and a shutdown in the supply chain that brings us most of our medical supplies, or many of our medical supplies, and that at some point made in America on our critical medical supplies will be really important. All right, the medical director, I just got to put in a good word since we just had our Eagles meeting a couple weeks ago, that the role of the medical director in this has been essential. Many of our EMS medical directors became very important in the public health system, became important to law enforcement, became important to corrections, became important to the bus drivers and to the park district and to public works. And I served as medical director for many of those groups in my metro areas, as well as my fellow Eagles who, like Rob Dunn in Detroit, was the medical director for the metro bus system, because those critical workers had to be protected, as well as the firefighters and EMS personnel working in the streets. And so we were learning our experiences across the Eagles, sharing them across the globe very honestly. And it was a very efficient process for us getting best practices out rapidly, and then understanding when best practices didn't work on the prevention side, what we were going to need to do to respond to the community, to develop more active treatment and testing, which we did as a group, developing those things, and then build it into a quality improvement process. Next events, who knows? They may be biologic, but they may also be nuclear or chemical or something else. And that, consistent in this industry, infectious disease good practices will always help us. So conclusion at 45 minutes here. Thank you for what you did. Thank you for what we still have to do. And thank you for contributing to the science that will make all of this better for future generations of fire and EMS providers. So at that point, I am going to shut up and I will stop sharing my slides. And John, do I turn it back to you for questions?
Yes. So, Doc, thank you very much. That was excellent. Very informative. I can tell you early on in your presentation, one of the things that caught me was PPE. I know in Syracuse, when we were kind of caught by surprise with the whole COVID thing, we actually, I would say, have had several moments of desperation where we weren't sure if we were going to have enough PPE coming in to continue normal EMS responses. The market was getting that tight. Big problem was a lot of the PPE that we all depend on was coming from overseas, and a lot of shipping was interrupted. So, but our situation wasn't unique. Fire and EMS agencies everywhere, even police to a certain degree, because they had to deal with the public, were having a very hard time finding authentic N95s, things like that. So it was a challenge for all of us. So,
Yep.
I'll stop wagging my jaw here, and Doc, I'll let you speak. And anyone has questions, please.
Yep. Wendy Norris, are you still seeing comorbidities impacting outcome of COVID recovery? And that is very clear right now. When I get hospital reports, and I get them from multiple markets, what we're seeing in the hospital now is generally people that have comorbidities that have led them, even with what would be otherwise a mild case of COVID, impacting their health, resulting in them dying. That in some patients, even vaccinated patients who had an immune system that wasn't receptive to the vaccine, that they're susceptible still to getting severe cases. In general, what is in the hospital now is not either vaccinated people or people with competent immune system. So that is the comorbidities, and in particular, people with underlying heart and lung diseases, obesity, and cancers are at particular risk of a really bad outcome of death or of substantial complications from their disease. We still have some people with Delta, who have been since the winter time, have been in nursing homes or other rehab facilities, and those people, when they die, are still related to as a COVID death. So yes, comorbidities very much still impacting the severe COVID that we're trying to avoid. Other questions verbally or in the chat box? All right, hearing none. John, do you want to do summary?
Sure. 100% sure that nobody else has questions. Want to make sure nobody's having an equipment problem where they can't either speak or get a message across. Going once. Okay. Just on my end, Doc, I wanted to say thank you very much. This was exceptionally informative and definitely well in line with what we're trying to do here. So if there's anything you'd like to add, we certainly, again, very informative, and I can't thank you enough for doing this today.
To you, to Brittany, to Sarah Janke, thank you very much. You put all this together. You help us all learn together. We have to take advantage of this opportunity. I say someday, 10, 20, 30, 40 years down the line, somebody's going to put COVID in line with our other risks. How did we manage this? What did we learn? And our responsibility is always to learn from each one of these events that impact us so very heavily, and the people that died of it, to make sure that we do it better the next time. And that's our opportunity right now. And that's the context I was trying to put around this. So thank you all again. Thanks to the organization of this. I'm available for questions if anyone needs to email me. My information is available from NDRI. Thank you all.
Thanks, Doc. Have a great day, guys.